Welcome to All in All. Today we're doing a deep dive into the world of dialysis. Specifically, we're looking at, what it means to be a dialysis RN or technician. And we're really zeroing in on team dynamics and how communication actually works inside the clinic setting.
Yeah, and our mission really with this deep dive is to kind of unpack the source material you've shared. We want to pull out those truly valuable insights for you. We want to understand the team, maybe why they work together the way they do, and then get down to the practical communication strategies you can use day to day.
Yeah, think of this as maybe collegial, a bit academic even, but definitely conversational. We want it to be engaging, tailored for you.
Exactly.
So let's jump right in. Who actually makes up this dialysis care team?
Okay, so when the sources look at the core team, who are the key players, it's really an interprofessional group.
Right.
You've got the nephrologists at the top, often seen as the team leaders. They guide treatment, they educate, and importantly, they encourage patients to really participate in their own care.
And they don't work alone, right? There are advanced providers.
Exactly. Working closely with them, you have advanced providers, could be nurses with advanced training, physician assistants collaborating on care.
Makes sense.
And then central to the day-to-day is the nephrology nurse. This is a really specialized role. They're doing those vital patient assessments, managing complex medications, overseeing the entire dialysis treatment itself.
Which is huge.
It is. And they often supervise things like home training programs, for HHD or CAPD.
And nutrition is obviously critical in dialysis.
Absolutely. So the renal dietitian is vital. They're helping with meal planning, tailoring diets, looking at dialysis adequacy from a nutritional standpoint, managing bone disease, anemia. It's complex.
Definitely. And there's a social aspect too.
Huge. The nephrology social worker provides that crucial psychosocial support.
Like counseling?
Counseling, helping patients and families cope with massive lifestyle shifts, emotional support, connecting them to agencies and resources,
Right.
focusing on quality of life, even practical things like employment.
And then you've got the folks doing the hands-on work every single treatment.
The dialysis technicians, the PCTs, absolutely indispensable on the front lines.
Can't run a unit without them.
No way. And the sources also mention the pharmacist managing those tricky medication regimens, thinking about how drugs are dialyzed, dosing adjustments.
Yeah, that dialyzability piece is key.
It is. And finally, the renal administrator. They're overseeing clinic operations, making sure things run smoothly, collaborating with the clinical team for quality care.
Wow, that's quite a lineup. But the sources seem to emphasize one member above all others.
They do, and that's the patient.
Yeah.
The patient and their family.
Oh, okay.
They aren't just passive recipients. They're positioned as the most important members of the team.
So they need to be active participants.
Absolutely. Encouraged to learn, to really engage, to participate in creating and following their care plan.
Okay, so we have this big, diverse team. Why? Why is this interdisciplinary approach so necessary, particularly in dialysis?
Well, kidney disease and dialysis, it's just incredibly complex. It's not just one medical issue.
Right, it affects everything.
Everything. Medically, physically, psychologically, socially, financially, you name it. And one single person just can't have all the expertise needed to address every single challenge these patients face.
It really does take a village, as they say.
It absolutely does. The sources really underline that a successful program depends on pulling together the expertise of everyone on that team.
Leveraging all those different skills.
Exactly. Working together towards the best outcome for often very complex patients.
And that brings us to this idea of a collaborative patient care model.
Right. This model really emphasizes teamwork, shared decision-making. It's about being responsive to what the patient actually needs.
Guided by evidence, I assume.
Guided by evidence, absolutely, but also considering factors from the patient, from the staff, the clinic environment, all aimed at ensuring quality care. It's about breaking down those professional silos.
Working as a unit.
As a true unit, yeah.
Okay, so we understand the why behind the team. Now, let's look at the how. How does this collaboration actually play out, especially around the patient care plan? The sources mentioned a shift.
Yeah, a shift away from just strictly following protocols towards more individualized, person-centered care.
Making it specific to that patient.
Exactly. And they use programs like My Dialysis Plan as a good example of this in practice. It's a structured approach to get patients more involved.
Okay, so let's walk through that process. What happens before one of these care plan meetings?
So preparation is key. Someone needs to schedule it, send out invitations, and crucially, right before the meeting, the team has a quick huddle.
Just the staff.
Just the staff, yeah, to quickly review the patient's latest assessments, any updates, just to get everyone aligned before the patient comes in.
Okay, makes sense. Then, during the meeting with the patient, what's the focus?
This is where the real collaborative work happens. The focus is on really listening to understand the patient's needs, their priorities, what matters most to them.
And using shared decision-making.
Yes, using those shared decision-making principles, which we'll dig into more in a sec, they work together to build an individualized plan. And this plan has specific, concrete action items.
For the staff.
For the staff, yes, but also, importantly, for the patient, too, giving them ownership.
Got it. And then what happens after the meeting?
Well, first, they review the plan again with the patient, make sure everyone's clear, everyone agrees. Then comes the follow-through.
Which sounds critical.
It is. Team members have assigned actions. They need to do them. There should be updates shared on progress, and the team needs to check back in with the patient, see how things are going, if priorities have changed.
Now, the sources mentioned a study looking at implementing this. What made it successful? What were the key ingredients?
Yeah, the study highlighted a few things. One was real deep commitment from the whole interdisciplinary team. Everyone had to be on board.
Buy-in is crucial.
Absolutely. Also, clear accountability. Who is responsible for each action item? And third, having a meeting structure that was organized, but also flexible enough to adapt to the patient and the situation.
Did they mention getting input beforehand?
Yes, getting input from both patients and staff while developing the program was really key to making it practical and workable in a busy clinic.
But it wasn't all smooth sailing, right? There were challenges.
Oh, definitely. A big one was consistent follow-up on those action items.
Even with electronic systems?
Even with platforms designed to share information, yeah. Making sure things actually got done and communicated remained a hurdle.
Interesting. Any other challenges?
There was also some initial discomfort among staff about leading these more patient-centered discussions, how to start them effectively, how to really draw out the patient's priorities, and how to wrap them up well.
That makes sense. It's a different way of interacting. How do they tackle that discomfort?
Well, the study found that developing specific tools really helped. Things like sample scripts for opening and closing the meetings.
Like prompts?
Yeah, prompts or guides. And also creating use cases examples linking common patient priorities to suggested action steps. These tools gave staff more confidence in facilitating those conversations.
Okay, that's practical. Now, you mentioned shared decision-making, SDM, a couple of times. This sounds pretty fundamental to this whole person-centered approach.
It really is. The sources define it pretty clearly. It's clinicians and patients making decisions together.
Using evidence.
Using the best available evidence, yes, but crucially, also respecting the patient's autonomy, their values, and really promoting their engagement in the process.
And the sources talked about the benefits of doing this.
Right.
What's the payoff?
Oh, quite a few potential benefits were highlighted. Think about it. When patients are truly involved, it can boost their knowledge about their condition.
Makes sense.
It can increase their confidence in managing their own health, that self-efficacy piece. It strengthens that vital relationship between the patient and the care team.
Builds trust.
Builds trust, exactly. It fosters patient activation, getting them more involved. And some studies, even in other chronic conditions, suggest it can lead to better patient-reported outcomes.
Any impact on healthcare use or satisfaction?
Potentially, yes.
Yeah.
Possibly decreased healthcare utilization, like fewer hospital visits. Increased patient satisfaction is a big one. Reduced anxiety, and potentially improved adherence or compliance with the treatment plan.
So real tangible benefits.
Yeah, it's not just a feel-good thing. It seems to have a real impact.
So how does this SDM process actually work? What are the steps involved?
The sources kind of break it down. It starts with building that trusting relationship, acknowledging the patient's emotional state, because let's face it, dialysis is tough.
Absolutely.
Then it's about discussing the clinical situation, the findings, but in language the patient can actually understand. Health literacy is key here.
Avoiding jargon.
Definitely avoiding jargon. Then the really crucial step is assessing the patient's values and preferences. What matters most to them? This helps them weigh the risks and benefits of options in their own context.
So they can lean towards a choice.
Right. It helps them reach an initial decision, or at least a leaning, and that's then discussed and reviewed together with the provider before finalizing the plan.
Are there tools to help with this? The sources mentioned something.
Yes, patient decision aids, or PDA.
PDAs?
Yeah. These can be things like booklets, websites, videos, audio recordings. Basically, resources designed to present information about options in a clear, unbiased way.
Based on evidence.
Has to be evidence-based, unbiased, verifiable. They don't replace the conversation, but they support it. They help the patient understand their choices better, feel more prepared for the discussion, and hopefully improve communication.
That sounds really helpful. But there was an important caveat, right?
A very important one. While we absolutely want to encourage and support SDM, we also have to respect the patient's wishes. If, after having the options explained, a patient clearly says, you know what, doc, I trust you to make the decision, we need to respect that too.
So autonomy includes the choice not to be the primary decision maker sometimes.
Exactly. It works both ways.
Okay, shifting gears a little from those formal meetings and big decisions. Communication is obviously happening constantly on the unit floor.
All the time.
And the sources brought up a specific technique called talking control. That name sounds interesting.
It does, doesn't it?
Yeah.
But it's actually quite interesting. It was studied specifically as a way to improve patient satisfaction with staff communication.
Okay, how does talking control work? What's the idea?
The sources describe it as being similar to befriending. The core idea is allowing the patient to lead the conversation, keeping it factual, sort of free-floating.
So not focused on problems.
Right. Within this specific technique, the goal is for staff to provide warmth, show interest, build rapport, but gently steer the conversation away from really deep emotional issues or major problems.
Towards more neutral ground.
Towards more neutral territory, yeah.
So what should staff actively do when using this technique?
Okay, the sources say, show genuine enthusiasm and interest. Be a sympathetic listener, but again, guide away from heavy topics in this context. Be non-judgmental.
What kind of topics work well?
Focus on neutral things, hobbies, current events, upcoming holidays. Maybe encourage talk about family and friends in a positive way. Use a neutral tone, words, body language.
Can staff share anything about themselves?
Yes, a little bit of self-disclosure in moderation can help build that connection.
And what should staff consciously avoid doing during these talking control interactions?
This is important for this specific technique. Don't go in with an agenda. Avoid focusing intensely on a key problem or a treatment concern right then.
So no problem solving.
Not collaborative problem solving during this type of chat. And don't suddenly shift to giving out educational flyers or laying out a specific plan of action. It's really about maintaining that positive, light, rapport-building presence.
Did they find it actually worked? Was there evidence?
Yes. The study they mentioned found a measurable improvement, about a 5 percentage point increase in positive responses on key patient satisfaction survey questions that were specifically about communication.
That's not insignificant.
No, it's a tangible difference.
Were there hurdles to getting staff to use it?
Oh yeah, the usual suspects. Getting full staff buy-in was one. Some staff apparently felt patient complaints weren't always valid or that this felt like just another task, extra work.
And finding the time, I imagine.
And finding the time, absolutely. Always a challenge at a busy clinic.
How did they get past some of that resistance?
Training was key, and reframing it helped. Instead of calling it a project, framing it as simply encouraging staff to take a little extra time to genuinely talk with patients seemed to improve buy-in from both staff and patients.
And leadership mattered.
Definitely. Having a strong project lead who really championed the technique, modeled it, was identified as crucial for success.
You know, it sounds like this technique, while specific, really builds on those broader communication principles we kind of intuitively know are important.
It absolutely does. Things like taking patient concerns seriously, explaining things clearly, really trying to understand the patient's perspective, active listening, spending enough time, showing respect, demonstrating genuine concern.
The fundamentals.
The fundamentals. Talking control seems like one structured way to help staff put some of those principles into practice consistently and build rapport, even when time is tight.
Okay, let's make this even more concrete for the RNs and techs listening. What are some everyday situations where effective team communication is just non-negotiable for workflow and, more importantly, patient safety?
Oh gosh, so many. Simple things first, like making sure the nurse or tech actually treating the patient knows if that patient has a care plan meeting scheduled.
Right, so they don't get put on the machine or taken off at the wrong time.
Exactly. Simple coordination, but vital. And sharing assessment findings effectively Before those meetings, maybe in those brief team huddles the sources mentioned, so everyone walks in with the same current information.
Yeah, avoids repeating questions or missing something important.
Totally. And think about that discomfort staff sometimes feel leading patient discussions for care plans. Having tools like those sample scripts or use cases developed in the study can really empower nurses and techs to feel more comfortable facilitating those crucial conversations themselves.
And following up. Communication about who's doing what after the care plan meeting.
Yes, we saw that was a challenge point. Just because it's in the plan doesn't mean it magically happens. Clear communication about who owns each action item and confirming completion is essential. Even with electronic records, that loop needs closing.
What about handoffs between staff?
Yeah, while the sources didn't detail specific handoff techniques, it's implicitly critical. Clear, structured communication during patient handoffs between shifts, between RNs and techs, is fundamental for preventing errors and ensuring continuity.
You also brought up patient complexity earlier. How does that factor into team communication?
It's huge. Understanding and clearly communicating a patient's level of complexity, are they stable and predictable or unstable and unpredictable, really dictates the intensity of monitoring needed.
And the level of collaboration required.
Exactly. It influences whether an RN might practice more autonomously versus needing immediate, close collaboration with a nephrologist, social worker, dietitian, etc. Think about complex situations like ICU hemodialysis or patients with really challenging access issues.
Or significant behavioral challenges.
Or significant psychosocial problems impacting their behavior on treatment. Effectively communicating these nuances within the team ensures that patient gets the right level of support and expertise right when they need it.
And speaking of access, that's a constant area for communication for RNs and techs, isn't it?
Oh, absolutely massive. Things like clearly identifying which accesses might need a more skilled cannulator. Knowing the protocol for when to consult the sources suggested consulting after just one unsuccessful attempt, which is interesting.
Yeah, that's quite quick.
It is. And consistently, clearly educating patients on how to protect their lifeline, their access, all of that relies heavily on good communication between the tech, the nurse, the educator, and the patient.
Okay, so pulling all these threads together.
Yeah.
What's the bottom line? What's the core role of RNs and technicians in making this whole team dynamic function effectively through communication?
Well, they are absolutely central. They're the ones with the most frequent, the most direct, the most sustained contact with patients day in and day out.
So they're really the ones making person-centered care and shared decision-making happen on the ground.
Exactly. They translate those concepts into reality during every interaction. Their communication skills, how they talk with patients, how they talk with each other, and the rest of the team has a profound impact.
On the patient's experience?
On their experience, definitely. But also on their willingness and ability to actually follow the treatment plan, their adherence.
And ultimately, their health outcomes.
And ultimately, their clinical outcomes. It all connects back.
And understanding what everyone else on the team does helps them do their job better.
Absolutely. By being aware of the roles and expertise of the dietitian, the social worker, the pharmacist, the nephrologist, RNs, and technicians are better equipped to provide truly holistic care.
They know when to handle things themselves.
They know when they can act autonomously within their scope, using their skills, but just as importantly, they know when and how to effectively consult and bring in other team members for those more complex issues or specialized needs. They're really the vital link, the bridge builders in the whole system.
That really underscores the significance of their role in communication.
It truly does. Their daily interactions are where collaboration becomes real.
Okay, as we wrap up this deep dive, here's a thought maybe to take with you. How can consistently prioritizing clear, empathetic, and collaborative communication with both your patients and your colleagues on the interdisciplinary team elevate not just the patient care outcomes, but maybe also the professional experience for everyone working in the dialysis unit?
That's a great question to reflect on.
Thanks for listening to All in All.